So very good morning students to all of you, and it gives me immense pleasure to say that we are now into the last part of the opioids. In the last session I dealt with specific agents like codeine. We also discussed about morphine dependence and tolerance and how to treat morphine de-addiction, how to go about for de-addiction. So in this particular section I would like to cover further some specific agents, and would like to begin the session with mixed agonist antagonists and partial agonists. Very good morning students, and as time is passing by, we know that each and every moment for a learner is important. It should not go waste, and we should be self-motivated. The motivation should be an intrinsic motivation to study, to complete the chapters, to master the analgesics or any other topics. So students, continue to read. That is my advice to you. And continue with the social distancing, continue to be at home. The COVID epidemic is still on, and we need to practice all the restraints we have been nicely doing up till now. So students, we continue with the mixed agonist, antagonists and partial agonistic drugs. There are those drugs that stimulate one type of opioid receptor but block another. When I say that, I am pointing towards pentazocine, because pentazocine is a kappa agonist and a mu antagonist. The effect of these drugs depend on previous exposure to opioids. Let us see how. In patient who has never taken an opioid, or a person who has never taken an opioid, the mixed agonist antagonist will show agonistic activity, and they can be used to relieve the pain, because suppose pentazocine we consider. Pentazocine is a kappa agonist, and I told you all the mu receptors mediate spinal and supraspinal analgesia. So the analgesia which will be mediated by the delta receptor, by the kappa receptor, will always, the benefit will be given to the patient. So it can be used to relieve pain, like postoperative pain. And if you are giving such drugs, mixed agonist antagonist drugs, to opioid dependent individuals, that means they are having they are already using opioids, and they are dependent on it. That means they are using the drugs which are habit forming. So if you give pentazocine, pentazocine will have mu blocking effects, because as you know, it's a mu antagonist, and that is going to precipitate a withdrawal symptom, similar to what an opioid antagonist, naloxone, is going to precipitate. So this is important for you to know. In opioid naive, they can be used to relieve the pain, but in opioid dependent individuals, you know, they can precipitate an acute withdrawal. So pentazocine will never be given for opioid de-addiction therapy. Methadone is the one which is preferred, not pentazocine. Methadone is a pure agonist, so that is going to be preferred, and not pentazocine, because pentazocine is going to produce withdrawal symptoms. Now coming in more detail to pentazocine, that can be asked to you as a short note. It is a agonist at kappa and the weak antagonist at the mu receptor. It relieves moderate pain. When I say that, it will not be so efficacious in relieving the severe pain, because the kappa receptor agonism does have ceiling effects as far as analgesia is concerned. It can be given orally and parenterally. That is its good part. It produces less euphoria compared to morphine, or rather it produces psychotomimetic effects or dysphoria, because it is antagonist at mu receptor and it is an agonist at kappa receptor. In doses, it does produce respiratory depression, but that respiratory depression may not be as severe or life-threatening as a pure mu agonist. At high doses, it increases the blood pressure and it can increase the work of the heart, because it causes sympathetic stimulation. So that is why even if we have pentazocine available with us in the hospital, we would never give it for abolishing the pain of acute MI, because acute MI is already a compromised situation where the demand of the heart cannot be matched up by the supply. The coronaries are absolutely blocked. So in that setting, if you are giving pentazocine, it is going to increase the blood pressure, which is not so welcome in a patient who's having MI. So pentazocine is never used to relieve a pain of MI. It doesn't antagonize the respiratory depressant action of morphine. Why it would do that? And because it is not a pure mu antagonist, it precipitates a withdrawal syndrome in a morphine abuser. I discussed it. And ceiling effects on analgesia and respiratory depression above 50 to 100 milligrams. If you recollect the dose response curve which was presented in the previous session of mine, we could see that the maximal effect of pentazocine like drugs is much less than morphine, is much less than pentazocine, and much less than methadone. So the ceiling effects are seen at doses, and beyond that we would not get any additive analgesic effects, or we would not have any additive respiratory depressant action. Now we come to another drug which is a partial mu agonist, and if you recollect the dose response curve again in my previous session, even buprenorphine is a partial agonist. Its intrinsic activity is less than morphine. That means it is somewhere between 0 to 1. Buprenorphine is a very lipid soluble opioid. It is a partial mu agonist and a kappa antagonist, and it is also one of the drugs which is now used for treating opioid withdrawal in subjects over and above methadone and buprenorphine. Both can be used. Buprenorphine has a good way we can give it to patients. It can also be used for breakthrough pain. It can be given sublingually, where it is just directly taken inside the mouth and the tablet gets absorbed inside the mouth, so that it's a thing which is useful. It is also 25 to 50 times more potent than morphine. Yeah, but efficacy wise it is less. Potency is decided by the dose students. But it's a partial mu receptor agonist, tightly binds to the mu. Whatever, it's a partial mu agonist, but it tightly binds to the mu. So it has less association with euphoria, which would be seen with other opioid agonists. It dissociates also slowly from receptors. These are also the features of methadone. So that is why buprenorphine and methadone do not produce a severe withdrawal. If given in opioid addicts, they produce a very protracted withdrawal, and the patient is out of the withdrawal having less cumbersome effects. Its half-life of dissociation is also long, which is 166 minutes, as opposed to 7 minutes of fentanyl, and it is absorbed by most routes, and it can be given sublingually, intramuscularly, subcutaneously, etc. And potential advantage of buprenorphine over methadone is that there is less withdrawal discomfort after cessation of buprenorphine. So even the methadone which you have started in an addict has to be tapered, has to be stopped. Patient is going to have methadone withdrawal also. So buprenorphine has even lesser withdrawal than what patient is going to experience with methadone. Now we come to this MCQ students, because we always have to test ourselves, test our basic knowledge whether we are going in the right direction or not. Morphine should be used with caution or not used in all of the following conditions except bronchial asthma, head injury, acute abdominal pain, and left ventricular failure. So students, let us start from the beginning. It should be used with a lot of caution in bronchial asthma, because it can itself precipitate an attack of bronchospasm, because it can release histamine. Histamine, as you know, causes bronchoconstriction. As far as its head injury use, pain of head injury abolishment is concerned, morphine is usually avoided and contraindicated, because number one, morphine is itself associated with a rise in the intracranial pressure, and so we will not be able to assess a patient of head injury, because we will not be able to gauge his sense of consciousness. We would not be able to, head injury itself is associated with sometimes a lot of vomitings, so we will not be able to differentiate whether this nausea and vomiting is because of morphine or some other reason, or because of head injury. So we will not be able to assess the signs and symptoms of head injury to assess the patient. It should not be used in any time in undiagnosed acute abdominal pain, because that abdominal pain could be a result of biliary colic, and you know that morphine-like drugs, they cause spasm of the sphincter of Oddi. They can worsen in a biliary colic and worsen an acute abdomen. So unless we know the cause of the acute abdominal pain, we should not go in for morphine therapy for undiagnosed acute abdominal pain. And left ventricular failure is the answer, where left ventricular failure accompanying myocardial infarction. I'll repeat here, this left ventricular failure is a temporary left ventricular failure, reversible left ventricular failure, and that is characterized by pulmonary edema, breathlessness, and morphine here helps the patient a lot by decreasing preload, by decreasing the afterload. That is, it does by because of its histamine releasing action. It also causes bradycardia, so that decreases the work done by the heart, it decreases the oxygen requirement of the heart, and Yes, morphine depresses the vasomotor center also, and that decreases the force of contraction of the heart. Morphine allays anxiety, which is associated with left ventricular failure, MI, so that it benefits in left ventricular failure. Although I told you that the studies conducted in our setup here, we did not find anybody using morphine because of limited availability and because of availability of other potent vasodilators like intravenous nitrates, which could do the job. Now we come to the following, which are the following opioid analgesics should not be used for pain of acute MI. I think I already answered it. Morphine is used to abolish the pain of acute MI. Buprenorphine can also be used because it is a partial mu agonist, and pethidine can also abolish the pain. It's a pure mu agonist. Pentazocine can abolish the pain. We can't say it doesn't abolish the pain. It can abolish the pain, but pentazocine over and above causes rise in the blood pressure, causes sympathetic stimulation, and that becomes one of the reasons for not using it for abolishment of pain of acute MI. So the answer here is pentazocine. Students, it should not be used for pain of acute myocardial infarction. These are the curves, or these are the severity of withdrawal. This figure reflects the severity of opioid withdrawal symptoms after abrupt withdrawal of equivalent doses of heroin, buprenorphine, and methadone. So if you see, the heroin withdrawal is very severe and very acute in onset. It is not a protracted withdrawal like of buprenorphine or methadone. And buprenorphine is used in opioid detoxification because it has a lesser severe, shorter duration of withdrawal symptoms even as compared to methadone. So shorter duration of withdrawal, that makes buprenorphine as one of the candidates for opioid detoxification therapy. Even methadone has this property of a protracted withdrawal. The difference between methadone and buprenorphine is that the withdrawal by buprenorphine is even less severe than methadone, and it is of a shorter duration as compared to methadone. So symptoms last longest with methadone but are less severe than those of heroin withdrawal. They are going to last long because methadone, as I told you, is having a half-life which is very long, and methadone accumulates itself in the extravascular tissues also, and you stop using methadone, the drug is released slowly from the extravascular tissues also, and then it stays in the body for a long time, so that precipitates a withdrawal. Now we come to a beautiful drug which is called tramadol, students. Tramadol is the only opioid which can be used for neuropathic pain, which is a type of a chronic pain. Tramadol is considered a safe drug, and it is a weak mu agonist, and over and above its being a weak mu agonist, students, it is also an uptake inhibitor of 5-HT and noradrenaline, a quality which antidepressants have with themselves. And tramadol, thereby, if it's a reuptake inhibitor, it has to be of some benefit in the neuropathic pain. Tramadol is a weak mu agonist. Incidence of respiratory depression with tramadol vis-a-vis morphine or any other potent opioid like fentanyl is very less. Of course, it does have ceiling effects with respect to analgesia is concerned, and they say it is not habit forming, it is not dependence producing. But yes, recently there were reports that tramadol is also dependence producing agent. But tramadol and tapentadol, one of the two drugs of this category, they are weak mu agonists. Its potency is 6,000 that of morphine, and part of its analgesic effect is due to inhibition of the reuptake of noradrenaline and 5-HT into the nerve terminals which release it. It is efficacious for mild to moderate pain, effective as morphine or meperidine, and it is for severe or chronic pain it is less effective, and that points to its mechanism. Nothing is, we have to remember, everything points to the mechanism action of the drug. It causes less neonatal respiratory depression because it is a weak mu agonist. It has a good bioavailability, and it has an active metabolite, which is the methylated metabolite, which is as potent as the parent drug, and it is supplied as a racemic mixture, more effective than either enantiomer alone. The plus enantiomer binds to the mu receptor, causes mu agonism, and inhibits the 5-HT reuptake, and the other enantiomer inhibits the norepinephrine reuptake and stimulates the alpha-2 adrenergic receptors. You know, alpha-2 adrenergic receptors also confers decreased noradrenaline release and a sympatholytic action to such an extent, clonidine, which is an alpha-2 agonist. So it's a tramadol which is very widely used drug, and you know, the brand name which is available is Contramal, which is a very common brand name which is available, and yeah, you can get it. tramadol has less respiratory depression, less degrees of constipation. I'm comparing it with the stronger opioids, but the problem with tramadol is that it can cause a lot of headache, it can cause a lot of dizziness. You know, the first dose of tramadol if somebody takes, he complains of a lot of dizziness. Also, we cannot say that it does not cause constipation. It does cause constipation, but that is a lesser as compared to morphine, but it can cause seizures and possibly exacerbate seizures. So patients who are having history of epilepsy should be given tramadol with a lot of caution, and tramadol should be combined carefully with other drugs which lower the seizure threshold, which are the antidepressant agents. You know, they are also seizure producing in nature, so tramadol should be effectively very combined with these antidepressant agents, especially the 5-HT reuptake inhibitors and the tricyclic antidepressants, with a lot of caution, because seizure producing potential can be exacerbated. The maximum recommended dose of contramal is 400 milligram. The low doses start from 37.5 milligrams, and side effects nausea, vomiting, which are very stark, and dizziness. I told you, for elderly, dizziness becomes a real problem. Dry mouth and sedation. Of course, it does produce sedation, headaches, and it can exacerbate seizures. So this is about tramadol. Students, be prepared to be able to answer a short note on tramadol, comparing it with the standard mu agonists. Now we come to the pure mu antagonists, and there are 3 in number: naloxone, nalmefene, and naltrexone, and they are competitive opioid antagonists. Naloxone will displace morphine from its binding site, and that binding is not non-competitive. It is it's a competitive antagonism, and which can be reversed if you increase the dose of an opioid agonist. Why I am telling you, repeating it again and again, is that once you are giving an naloxone for treatment of opioid poisoning or opioid overdosage, we cannot just rest by giving 1 dose of naloxone, because that will not help the patient. Patient will come out temporarily from respiratory depressant action, but he will sink back again to respiratory depression if we don't repeat the dose of naloxone, because this binding is a competitive binding, and its effects will be reversed. Effects of naloxone will be reversed if the opioids are larger doses in the body, which they are going to be there in opioid poisoning. So naloxone has to be given repeatedly in cases of opioid overdosage or treatment of opioid poisoning. It very strongly reverses the effects of opioid agonists. It reverses not only the respiratory depression, not only the sedation which is given by opioid, but it also reverses the analgesic effects of morphine. Yeah, I'm busy. Naloxone is an opioid antagonist. It produces no pharmacological effects on its own. It reverses the coma and respiratory depression of opioid overdose, and patient becomes revived and alert. It displaces the bound opioid molecules rapidly, and I told you it's a competitive antagonism. Half-life is 60 to 100 minutes, and dose is 0.4 to 0.8 milligram intramuscularly or intravenously, and this dose has to be repeated in order to prevent person sinking back again into respiratory depression. Patient treated and recovered may lapse back into the respiratory depression. It precipitates withdrawal symptoms in opioid abusers, as I discussed you, because it's naloxone, which is a pure mu antagonist, and this characteristic it shares with pentazocine, which also precipitates withdrawal symptoms in opioid abusers. So let us come with this MCQ. In case of an opioid overdose, naloxone can be given in repeated doses. Because of which property of naloxone? I told you we have to repeat the dose of naloxone. 1 dose may not be sufficient. Why? Because may have a shorter half-life than opioid agonist, is effective only at high cumulative doses, is needed to stimulate the respiratory center, is safe only in extremely small doses, is only a partial opioid agonist. Let us go from down, students. It's not a partial opioid agonist, it's a pure opioid antagonist. It is safe only in extremely small doses. No, it's not like that. Small doses are effective to reverse the opioid overdosage. Is needed to stimulate the respiratory center. That's not the reason. It is not. It's not the reason that it is effective at high cumulative doses. It has a shorter half-life than opioid agonists. So ultimately, the thing is competition at the opioid receptors. If there are more opioid agonists crowding the receptor, then the block of naloxone will be reversed, because you know that block by a competitive antagonist is insurmountable. It's a surmountable antagonism. So remember this. This is the reason why it is given. We can also use naloxone orally for use of this overdosage. We are giving it intramuscularly or intravenously, but we can give naloxone orally to reverse the peripheral side effects of the opioids. Because you know, people who are taking opioids for pain relief, they will have various side effects associated with opioids, like constipation, to which tolerance does not develop. So low dose naltrexone, that is 0.04 milligram, is useful in treatment of adverse effects commonly associated with intravenous or epidural opioids. One of the naltrexone opioid antagonists, which is methyl L is missing here. Methyl naltrexone bromide is approved by FDA for the treatment of constipation in patients with advanced disease. It does not cross the blood-brain barrier, so it won't reverse the analgesia, but it will kind of reverse the constipation by antagonizing the peripheral mu receptors, students. Now we come to another oral opioid agonist, naloxone, and the other drug is naltrexone. Naltrexone is a pure mu antagonist, and it is orally active congener of naloxone. Naloxone is given for opioid overdosage. It can be used for the life-threatening opioid overdosage, where it reverses the respiratory depression very starkly. Naltrexone is an orally active pure opioid antagonist. Naltrexone does not has a very long duration of action. You know, in comparison to naloxone, naltrexone has a very long duration of action, and it can be given for maintenance of opioid de-addiction, not for the acute de-addiction management, but it can be given for post-addicts, because you know, post-addicts who have been discharged home, they can be given naltrexone 50 milligram once a day. Naltrexone will bind to the opioid receptors very strongly. It binds to the receptors very strongly, and even if the patient, you know, loses away his control over the opioids, he procures opioids again to use it, he will never be able to perceive the pleasurable effects of the opioids, because they have already been, the receptors have already been blocked by naltrexone. So naltrexone is not used for opioid overdosage. Naltrexone is neither not given immediately for withdrawal, but it is given to post addicts. Remember, this use is very specific for naltrexone. The only problem with naltrexone is that it is hepatotoxic. That is its only problem, and that hepatotoxicity can be cumulative on repeated doses. Its actions are very similar to that of naloxone. It has a longer duration of action than naloxone. It binds the receptor more tightly. It is given only and only by oral route. Naloxone is given primarily by the intravenous route. It is used for the maintenance therapy for addicts in treatment programs, in de-addiction programs. It blocks the pleasurable effects of heroin. This would be expected to discourage continued drug abuse. It is given for post-addicts. Remember that patients must be fully detoxified from narcotics before beginning the therapy. It is beneficial in treating chronic alcoholism by an unknown mechanism. So it decreases craving, which is associated with chronic alcoholism, de-addiction. It is also used not only for morphine de-addiction, but alcohol de-addiction also. And its hepatotoxic dose is 50 to 100 milligram just once a day. And now in patients, you know, who need the opioids, there is a new drug delivery which has come in, and that is called the patient-controlled analgesia. That's patient-controlled analgesia intraspinal infusion, where the pump is implanted inside the skin. A catheter running away from the pump is placed inside the spinal fluid space, and the pump rate can be controlled by an external telemetry device. So that is a patient-controlled analgesia, some new way, and depending upon the requirement of the person, he can press the pump, he can control the pump rate, and usually it is reserved for people who are having terminal pain and where we are not so much bothered about addiction. We just want a good life for the patient. In that case, patient controlled analgesia is one of the routes which is preferred. Even the analgesics like opioids can be given by rectal administration. Morphine, hydromorphone, oxymorphone are available as rectal suppositories, and they are well tolerated in most children. They can be given as a oral transmucosal administration, especially fentanyl can be given for that. Transdermal fentanyl is available, or ionotophoretic administration, where the drug is applied on the skin. A current is passed, and that will enhance the absorption of drug molecules inside the skin blood vessels directly to the systemic circulation. Over and above its analgesic use, morphine and other opioids have two main uses. One is its use in the treatment of dyspnea, and second is its use as a pre-anesthetic medication. So this is the use for which we are talking about, the pain of terminal illness and cancer pain. It is not indicated in all cases of terminal illness, but the analgesia, tranquility, and even euphoria afforded by the use of opioids can make the final days of a person less distressing for the patient as well as his family. No patient should ever wish for death because of physician's reluctance to use adequate amounts of effective opioids, and that may entail the regular use of opioid analgesics in substantial doses. Such patients may be physically dependent on the opioids, but they are not addicts, even though they may need very large doses on a regular basis. Remember, students, physical dependence is not equivalent to addiction. Now, I was talking about in my previous session about the WHO analgesic ladder, which is given by the World Health Organization, which categorizes or gives a three-step approach to pain relief. First is step 1, which is mild pain, which has pain scores of 1 to 4. 10 is a maximum pain score on the visual analog scale. 1 to 4 is a mild pain score. You can target it with non-opioid analgesics, paracetamol in larger doses up to 1000 milligrams, and non-steroidal anti-inflammatory drugs. We have many such drugs in our kitty: diclofenac, ketorolac, we have ibuprofen, we have mefenamic acid, many such drugs. We have already studied that, students. Now, if the pain relief is uncontrolled by that, we go to a higher step 2, which is moderate pain scores of 5 to 7, and we can start here with the weak opioids, codeine, hydrocodone, and tramadol. And still, if the pain relief is not adequate, we can go for step 3, which is severe pain scores between 8 to 10, and stronger opioids may be indicated here: morphine, oxycodone, hydromorphone, fentanyl, and methadone. They are strong mu agonists. And this is the WHO organization analgesic ladder in little more detail. Step 1 is mild to moderate pain. So you can go for a non-opioid drug with an adjuvant agent. What's an adjuvant agent? An adjuvant agent can be anything which is supplementing to the efficacy of the prime pain relieving drug. It can be an antidepressant. It can be any drug for neuropathic pain like duloxetine. So adjuvant agents are those that enhance the analgesic efficacy, treat concurrent symptoms that exacerbate pain, and provide independent analgesic activity for specific types of pain. So clonidine here also will act as an adjuvant agent. So non-opioid or an adjuvant agent for mild to moderate pain is what we have to give. Paracetamol or any other NSAID should be used unless contraindicated. So that is the treatment for step 1. We go to step 2, which is mild to moderate pain, or a pain which is uncontrolled after step 1. You have to start with a short-acting opioid as required, and plus a non-opioid like an NSAID round the clock. ATC is around the clock, plus or minus an adjuvant agent. So which can be a short-acting opioid. It can be morphine, oxycodone, or hydromorphine, and that should be added to paracetamol or an NSAID around the clock for maximum flexibility of opioid dose. Now, step 3 is a moderate to severe pain, or pain which is uncontrolled after step 2. So here we would like to give sustained release long-acting opioids, students, over the counter or continuous infusion or patient control analgesia, plus short-acting opioid for breakthrough pain in the form of fentanyl or buprenorphine, plus minus non-opioids, NSAIDs can be supplemented, plus minus adjuvant agents. So for short-acting we can give fentanyl, and sustained release we can give oxycodone, morphine, or oxymorphone. Now we come to another new drug which has recently joined the kitty, and the name of the drug is ziconotide. You know, it's a non-opioid basically, and we have come to know recently that marine toxins, snail toxins, which target the GPCRs, and they act on the neurotransmitter transporters, inhibit the release of the pain-producing neurotransmitters. One which is FDA approved recently is for the treatment of chronic pain is ziconotide, and it is nothing but a synthetic copy of the neuroactive cone snail toxin. It blocks the N-type calcium channels on the nociceptive efferents in the dorsal horn of spinal cord, and what it does, it leads to blockade of the neurotransmitters involved in nociception. The drug name is ziconotide, which is the latest to be approved by FDA. It is given by the intraspinal route as well as continuous infusion by a controlled microinfusion pump. The dose is begun from 2.4 microgram per day, increased up to in increments of 2.4 microgram per day up to a maximum of 19.2 micrograms per day. It is used to treat severe pain in whom all other treatments have failed, or in whom opioids cannot be given because of some contraindication, or who are allergic or unsuitable for opioid use. Hallucinations can happen with this drug, which are very, very common, so these drugs should be avoided in patients with underlying psychosis or other types of psychotic disorders. It is not an opioid, so its effects are not reversed by naloxone, so it is not a mu agonist, that its effects will be reversed by naloxone. It's a drug which actually blocks the calcium channels, and that will prevent the neurotransmitter release. So students, that brings an end to the analgesics and NSAIDs as well as opioids, and they have been prepared part-wise for you to understand. Please write any question you need to ask in the comment section, and we would be more than happy to answer you. Yeah, thank you so much, students, for learning the pain relievers with me. I'll come back again with further lectures, because this lockdown is going to go beyond at least these 14 or 15 days. We are in a state of complete lockdown. Especially what happened in Nizamuddin, many people have been have died, as I read in the morning, as I gathered in the morning. So it's not still the end of the outbreak. Of course, social distancing is playing its part, but yes, it's not the end of the outbreak. So we continue to read like that. And students, I'm liking to connect with you in this way. Thank you so much.